Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 20, Ultrasound. Today I'm going to talk a bit about scans, the use of ultrasound in pregnancy, what it's like to learn to scan, and how we use it. These days it's really hard to imagine obstetrics without ultrasound. And yet, when I thought about making this episode, I thought I'd look back at the history a little bit before beginning. It's quite astonishing that it's such a recent invention. When I delved into it a little bit, the first papers were published in 1958 about the physics and safety of using static ultrasound in pregnancy. Static because it wasn't pictures, images in real time. The first use of ultrasound in pregnancy was to look at the location of the placenta. And that was because up till then, it wasn't possible to diagnose placenta previa, a low-lying placenta. And because this can cause significant hemorrhage, bleeding from the mother, it was really important to be able to try and visualise where the placenta was. So the first thing that they looked at was identifying the location of the placenta from the 60s. And in the early 70s, they started to be able to take measurements of the baby, the fetus. In the late 70s and 80s, real-time ultrasound started to be able to detect anomalies, so structural problems with the developing baby. So, like I said, a relatively recent addition. And now it's pretty unthinkable to imagine obstetrics without ultrasound. An ultrasound machine is now a common piece of kit on the labour ward. We've got a small portable scanner on wheels, easily moved from room to room, and we can check the baby's heartbeat, we can check the baby's position, we can use it all the time, day to day, multiple times a day. But when I started out, we didn't have a dedicated scan machine for the labour ward. When we decided we needed a scan machine on labour ward, we basically got the cast-off machine from the radiology department. So ultrasound machines, technology's moving on apace and they need regularly upgrading. We literally had the huge lumbering great machine that was outdated and that the ultrasound department were getting rid of. And if we wanted it, we could have it on labour ward because otherwise it was going to be chucked away. So that's how we started out with ultrasound on the labour ward. It wasn't really designed to be moved around and it was a really cumbersome piece of equipment. Scanning started to be a key skill as an obstetrician and gynaecologist, both for diagnosing problems in early pregnancy and checking basic fetal heart and which way up the baby was, breech presentation or head presentation, cephalic presentation on the labour ward. Nowadays, basic scanning is part of the curriculum. So all trainees go through a programme of learning basic gynaecology and basic obstetric scanning so that they can identify key features, take key measurements. And the way we do that in our unit is they have a dedicated week or two with the sonographers learning scanning skills. In my training, it wasn't so systematic. It was much more haphazard. It was much more you scanned if your consultant scanned. So if your consultant was in a subspecialty, maybe fertility or early pregnancy where you were exposed to scanning, or fetal medicine, And if your consultant didn't scan, then you didn't. And learning to scan is quite tricky. So first of all, you've got to learn to orientate the probe. And then immediately, although it seems a little bit mad, you've got to decide which hand you're going to scan with. The first time I learnt to scan, I obviously used my right hand. That's my dominant hand. So I would be sitting and the patient would be to my right, the woman would be to my right, and I would use my right hand to scan. And I learned with the patient's head behind me. So I wasn't making eye contact with the patient, but she could see her baby on the screen quite easily. The room is dark so that you can see the screen properly, see the images properly. And so it's quite odd sitting in a dark room with a woman who's essentially sort of sat behind you scanning. And initially when you start scanning, the images look incomprehensible. So it just looks like an old-fashioned TV with that kind of snowstorm, grey, white and black pictures. You can't really make anything out. But the more you practice, the more you start to be able to discern, the more you start to understand what you're seeing and how to get the right images. So a little while after I'd started, one of the consultants I was scanning with, who was much more serious about scanning and interested in fetal medicine, explained that actually, although I was right-handed, I needed to learn to scan with my left hand. And the reason for that is that if you scan with your left hand, you can do invasive tests under ultrasound guidance with your right hand. So you can hold the probe with the left and you can take your needle, perhaps if you're doing an amniocentesis, and put it in with your right hand. So that switches everything round. The woman is then on my left and I'm scanning with my left hand, which feels really counterintuitive. But they're absolutely right, because when I learnt to do an amniocentesis, which is taking fluid from the amniotic sac to look at the baby's chromosomes, which we used to do much more often, you can then see and follow the needle with looking with your probe, while with your right hand you're putting the needle in and taking out the fluid. So consultants who were key in fetal medicine, and amnio is just one invasive test that you can do in pregnancy, tended to scan with their non-dominant hand and use their dominant hand for procedures. So as I've just mentioned, I learnt to do amniocentesis. We used to do them quite a lot. People used to have a screening blood test, and if that came back so-called high risk, a higher chance of 1 in 200 of Down syndrome, we used to offer them an amniocentesis. And that was difficult because that had a risk of miscarriage as well. And ultimately, it was done at about 15, 16 weeks of pregnancy. So it's quite late if you do have a problem to find out about that problem and decide what you're going to do. Are you continuing the pregnancy or not? And I'm not going to talk about the ethics of that today, because I might talk about that in a different podcast, whether or not we should be screening for something like Down syndrome. But that was amniocentesis, and it was something that we pretty much all learnt to do. It wasn't something that a few specialised people did. We all learnt to do it. And before I learnt to scan, I'd already learnt how to do an amniocentesis. I worked in a hospital where a sonographer would scan, and with a biro, they would literally mark on the woman's abdomen where to put your needle, and literally X marks the spot with a biro, and we would put the needle in there. And of course, you wouldn't know if the baby had moved and whether that was still where the pool of amniotic fluid was or not, but that was how we did it. So for me, when I started being able to scan myself and literally watch the needle going in to take the fluid, that felt much safer, much better, much more skilled. And then the further development was something called chorionic villus sampling, or CVS, where you actually took tissue from the placenta. And by the point that that was becoming much more commonplace, you could do it in the first 3 months. So before or around 12 weeks, it started to be realised that actually a small number of people, specialists, should be doing these sorts of procedures to minimise the risk of miscarriage or damage to the pregnancy. And that really everyone shouldn't be learning to do all these tests. So I never learnt to do that. But I was very interested in scanning. I think because I worked with a consultant who was passionate about scanning and passionate about fetal medicine. And so I learnt to do the different sorts of scans. So every woman usually has a minimum of 2 ultrasound scans. The first scan is the so-called dating scan. This checks the woman's dates, and that sounds a bit mad. And I know people find it difficult to understand when they definitely know when their last period was and they definitely know when conception might have been. But we're checking the dates because a lot of women don't. And at the beginning of pregnancy, babies are very uniform in size. And so this can help us accurately decide their estimated delivery date, or EDD, and can help us check the basic anatomy. Has it got limbs? Is the spine formed? And we take a measurement called the crown rump length, so from the top of the baby's head to its bottom, and that helps us date the pregnancy. Then we look at other basic anatomy, stomach bubble, perhaps are there 2 babies or 3 babies? Is it a multiple pregnancy? That's the time that's usually diagnosed. And we take a measurement called nuchal translucency, which is literally a fluid line at the back of the baby's neck if the woman wants screening for Down syndrome. And that's become a commonplace screening test during the course of my career. So I learnt to do these first dating scans, and I learnt to measure nuchal translucency, and we had to do a certain number. I can't remember if it was 50 or 100, and take the images and send them off to the Fetal Medicine Centre where they'd done the original research to make sure that you were taking the right images, taking the right measurements, so that you were being able to give women accurate results. Then I learnt to do the anomaly scan, and the anomaly scan is the 20-week scan, usually between 18, 22 weeks. And this is a thorough top-to-toe check of the baby's anatomy, so you can see much more detail at this stage. So we can measure the baby's brain, parts of the baby's brain, the heart, 4 chambers, where the placenta is, the lips, the palate, the profile, fingers, feet, and again, spine. One of the most difficult things I found to see were the baby's kidneys. And I remember I used to scan and check what I thought I saw, and then my consultant used to double check everything. Or he used to stand behind me and ask me to demonstrate what I could see. And I always struggled with the baby's kidneys. To me, they were incredibly difficult to see, very elusive. And he would point at the screen and go, look, there are the kidneys. Here's the left one. Here's the right one. And I would look at the screen and kind of go, oh, yeah, I see them. Whilst really thinking, I'm not sure with the eye of faith, do I know what I'm really looking at? And I don't know at what point it finally clicked, but now when I scan and I look at the baby and I look at the abdomen, I can easily see the kidneys. I have no idea why I found it so difficult to see the kidneys. It's almost like something just clicked, like a switch in my brain, and suddenly my brain could recognise what I was seeing. So we do a full top to toe check of the baby at that stage, and we also take measurements. And this is where it's a bit difficult because scanning has become more and more sophisticated over time. The machines are much better, and our knowledge and understanding of what anatomy looks like as it develops in the baby is much better too. So there are things that we perhaps saw when we were starting to scan that we couldn't really interpret, or we interpreted incorrectly. An example of this might be choroid plexus cysts. So these are small fluid-filled spaces in the lateral ventricles of the brain, so part of the developing brain. And we would see them quite commonly on the 20-week scan. And there was initially thought to be quite an association with fetal abnormality, such as trisomy 18. So that's babies that have an extra chromosome 18, which unfortunately isn't compatible with life. These babies tend to either die in pregnancy or after a few weeks, or maximum month or two. So we would see choroid plexus cysts, and then we would have a conversation with women about what they meant, and did they need to have further tests, and we would rescan and have a look at the rest of the baby. And this provoked anxiety. This caused worry for that woman through the whole of the rest of her pregnancy, that there was a possibility there was something wrong with her baby. And trying to explain to women that the baby had a small cyst in the brain is very disconcerting. Women find that very worrying, the idea that there's a problem with their baby's brain. And now we know more. We know that a choroid plexus cyst, an isolated cyst in the absence of any other abnormality, is a completely normal variation with absolutely no clinical significance, and is present in 1 to 2% of developing babies at the scan. So we've gone from a point years ago where we would tell women there's a choroid plexus cyst, and we would give them choices as a result, and we would worry them as a result, to a point now where that's a normal finding. We don't even mention it in the report. It's just a normal variation. So we have to be a bit careful as technology evolves, that knowledge can be a good thing and a useful thing, but actually it can provoke more anxiety and more problems as we discover things that we couldn't previously identify. The other key piece of information that people often want to get at the anomaly scan, the 20-week scan, is the sex of the baby. Couples knowing the sex of their baby in advance has become much, much more widespread. It's much less common on the labour ward when I ask if a couple know what they're having, for them to say, we don't know, it's a surprise. So many people now find out in advance, and in some ways that's excellent, that's a choice, that's perhaps a way of starting to bond with your baby and thinking about names of your baby. But for me, some of the special moment of birth is, who is this person? We didn't know who this was. We don't know if it's a boy or a girl. After 9 months of waiting, there's a surprise. There's a element of sheer excitement at finding out this information. So a lot more people do find out now. And there's the kind of American custom developing now of revealing the sex of the baby through a balloon or a cake or all sorts of other paraphernalia. But I find that a little bit sad. For my own children in my own pregnancies, it was really difficult. I didn't want to know in advance, and so I told the sonographer doing my scans to warn me when she was looking at the abdomen, looking at the pelvis, so that I could look away, so that I could avoid finding out in advance, because I really didn't want to know. I wanted to have that special moment at the birth. And really with ultrasound, the question is practice, practice and more practice. And when we take measurements, we measure 4 specific measurements. The biparietal diameter, that's across the baby's head from side to side. The head circumference, round the head. The abdominal circumference, around the tummy. And the femur length, the thigh bone. And we take multiple measurements because actually, to be accurate, you need to get a very specific cross-section through the baby and take 3, 4, 5 different measurements of the same thing, and then take the best section or the average of what you've measured to try and get the most accurate measurement. And a lot of machines now you can draw round, but some machines would generate a kind of computerized circle, and then you'd have to try and fit that. You'd take the view that you wanted of the baby, you'd freeze your screen, and then you put the calipers, the measurements, on the baby, and then this would generate a circle, and you would try and fit it as closely as possible to the section of the baby that you were looking at. And you do that 3 or 4 times on 3 or 4 different cross sections to make sure you have the right anatomical landmarks to get the accurate measurements. So it can seem a little bit like we don't know what we're doing, or that we're checking or practicing, but actually what we're doing with that repetition is trying to get the most accurate measurement possible. And when we're doing growth scans, the scans need to be at least 2 weeks apart for us to look at the growth velocity, the growth rate, how the baby is growing over time. Because if you do the measurements too close together, you won't get enough difference. The scan reports then take the measurements, those 4 measurements we've talked about, and do a calculation that brings up an estimated weight. And this is commonly used, the Hadlock calculation, and that was developed in 1985 and is still in use today. It's still the standard way of calculating the estimated fetal weight. We also look at the fluid, the water around the baby, which appears black on the screen, and we can use blood flow tests, Doppler tests, to look at the blood flow in the umbilical cord or within the baby, and I'll talk about that a bit more in another episode. There's quite a margin of error with scans. It may be due to the baby's position. It may be if the woman is very overweight, it's difficult to get good views. It may be that the woman has perhaps fibroids, muscular growths on the womb that are casting shadows. And it can get much harder to measure the baby's head as the baby's head engages into the woman's pelvis, because you get shadows of the woman's bones. So it can become quite difficult, and we have to be cautious, therefore, when we're making decisions on the basis of scans. I did an entire ultrasound diploma as part of my training. Why did I do that when I don't do that much ultrasound now? It was a whole extra exam that wasn't necessary. After taking all my professional exams, I chose to do it. And after I'd done it, I actually made my husband promise me that he would never let me take another exam, whatever I said, whatever I argued, whatever I wanted to do. Because in your late 30s, who wants to be taking exams? You really don't. You want to be moving on with your life. So it was very beneficial that I did the ultrasound diploma. It gave me a lot of knowledge and I did a lot of hours of scanning. But in the end, I decided I didn't really want to specialise in fetal medicine. I didn't want to spend my life doing scans in a dark scan room, potentially telling people difficult news. And so I decided, I'd done my scanning. I enjoyed my scanning. It was helpful to my career, but it wasn't something that I wanted to subspecialise in. And so now I scan ad hoc on the labour ward. I don't have a scan list. But I think I learnt a lot through doing that diploma, and that certainly helps me understand and interpret scan results much better than if I'd never done that during my training. I hope that's given you a little bit of a view of scanning and ultrasound. So now it's time for the zesty bit. And I think today's zesty bit is that nothing is 100%. So no scan is 100% going to tell you all the information you want to know about a baby. We need to be honest about the limitations of scans. They can act as a guide, they can help us, but they rely on interpretation, they rely on estimation, they rely on intelligent application. It's a tool, it's an extremely useful tool, but it's up to us how we use them and use them properly. And given some of the lessons we've learnt in the past about things that actually were normal variations on development that we didn't recognise as that, such as the example of choroid plexus cysts I gave, we need to be cautious when we're telling women about what we find on a scan, that we really understand what we're seeing and what the implications might be, and that we're not just increasing anxiety and causing unnecessary stress. Ultrasound has been an amazing development and is incredibly useful, but it's only one tool in our toolbox. For pregnant women and their partners, I hope this has explained and demystified ultrasound a little bit, and given you a bit more of an idea of what we're looking at when we're looking at your baby and what we're hoping to see and how this might help you with your pregnancy and help us look after you. But understand, scans are not 100%. Scans are not the be-all and end-all. Scans are only part of the information and part of the conversation that you need to have with the people looking after you. I do often have people come to clinic and ask me for a scan. And sometimes that's useful and beneficial, and I agree. And sometimes I explain, actually, in this situation, I don't think a scan is going to be useful. Yes, maybe you can have one, but actually, let's talk about why you want one and what it might help us with and what actually it might just confuse and be unhelpful in thinking about. So that's today's zesty bit. So I do hope you've enjoyed listening to the obstetricians. If you have, do like, subscribe or leave a review, and join me again to explore more about the life of an NHS obstetrician. I'm finding it really exciting to have people listening and give me feedback about what they've found interesting. So please do recommend the obstetricians to other friends, colleagues, or people who you think might find it interesting. I'd love it if you'd share with me what you've enjoyed about listening and if you've done anything differently as a result. I can be found on Twitter at FW Maternity and at the obstetricians. And please do check the MatExp hashtag MATEXP, and the website matexp.org.uk for more information and ideas on how to improve women's experience of maternity care. Finally, I'd like to reassure you that I take confidentiality very seriously, and although I'm talking about experiences from my working life, I'm taking great pains to make sure that I anonymise the stories and talk in more general terms so that I keep confidentiality of my women I currently care for and have cared for in the past very safe. Many thanks for listening.